you don't mind. Okay, so thank you very much for everyone for joining. We are so pleased to have Dr. Kisha Davis with us today. I'm just going to give a very brief introduction, if you don't mind. So Dr. Davis is a family physician and the Chief Health Officer for Montgomery County. She leads a lot of key public health efforts to support the health of our diverse community. She has a strong background in health equity and previously served as Vice President for the Health Equity at Aledade, working to reduce disparities in primary care across the country. Dr. Davis has also been active in the American Academy of Family Physicians for more than a decade, serving on the board and several national committees. We're so grateful to have you here and speak with us today. So Dr. Davis, please take it away.
All right. Thank you. Good evening, everybody. Thanks for spending a little bit of time this evening. Excited to be here. Thank you again for all of the support that the Medical Society has given me. I'm just getting back from the AMA meeting yesterday. Monday, we wrapped up Monday night, and got to sit with Dr. Kelly at the table. The AAFP table was conveniently right next to the Maryland table, so we got to conspire a little bit, so that was a lot of fun. And so I am really excited that us as a medical society has taken an interest in public health and thinking about ways that we can partner together. So I'm going to share a little bit about the local health department, what we do, what it looks like, who we serve, and then I hope to not take up all of the time and have a conversation around potential opportunities for partnership and collaboration, and also hear things that are troubling you, getting in the way, and how we can help. So let me jump in and share my screen here. Right, let's go into presentation mode. Okay, so local public health in our community. So goals give you kind of an understanding of the core functions of public health, consider some of the health equity implications, and in doing so, look at the county. What are the demographics of the county? Explore some public health that should be career opportunities, that should be collaboration opportunities, and a little bit about what makes the Montgomery County Health Department unique. And so in general, who we are, who we serve, and how we help. So what's public health? It's what we do as a society to collectively assure the conditions in which people can be healthy. The reason I went into public health, I started out of residency at a community health center in Columbia, Maryland. I loved it. Patients were complex. We did a lot for diabetes. We had nutritionists and we had the podiatrist that came, and we had group visits, and we were doing the new medicines even at a community health center. And I felt like we took really good care of the patients who walked through our doors with diabetes. And none of those things that we did helped me from having one more patient with diabetes because it was so far upstream. And I got really interested in how do we build healthier communities so that we can have fewer people with diabetes. And that's really that interplay between public health and primary care. And so what do health departments look like in Maryland? And health departments are very different even within the state. If you've seen one health department, you've seen one health department. Montgomery County, we are a health department serving 1 million residents. I have a friend in rural Kansas, and she's health officer to 2,000 residents. It's smaller than my high school, right? So the depth and breadth of what health officers do, what we do is the same. The number of people that we serve can be really different. This is the director of the Department of Health and Human Services. So one thing that makes Montgomery County unique within the state of Maryland is that we have an integrated Health and Human Services department. That means the traditional, what you think of as health department, sits under the same roof with our human services, things like homelessness, aging and disability, behavioral health, children, youth, and family. I'll go into a little bit more about that. But that is unique in the state. The closest thing to it is Baltimore County, but Montgomery County actually did a constitutional amendment to the Maryland Constitution to be able to have a carved out health department, which means unlike other health departments, I am the only state employee, well, myself and the social services officer are the only state employees in the health department. It's all staffed by the county and mostly paid for by the county. In other health departments, they are state employees who are doing the work. Our director, Dr. Bridgers, you may be familiar with him. He was deputy health officer under Dr. Gales, and then he was health officer for one day. And at his confirmation hearing for becoming health officer, or not health officer, chief of public health, he was then tapped to be acting director and then ultimately official director of DHHS. And his priorities are really around ready access, painless navigation, infusing equity throughout all we do, and an effective and supported workforce, which is can be difficult in days when it feels like public health is getting attacked. So, as I mentioned, the Department of Health and Human Services with Dr. Bridgers as the director. I sit under him as chief medical officer, chief health officer, really to bring the integration across the 5 different service areas. So those service areas that you see in the middle are children, youth, and families. That includes things like our gang prevention network, our child care alliance, our a lot of our liaisoning work with Montgomery County Public Schools, our youth safety initiative I used to lead, and now that has been turned over to children, youth, and families. Aging and disabilities, which includes our area aging agency on aging, home and community supports, adult protective services, lots of supports for the disability community, both intellectual and developmental. Behavioral health and crisis services, which includes mental health services. The county has access to services. We provide behavioral health treatment for folks who have Medicaid. Often I'm able to get somebody in with Medicaid into that faster than in the community. We also have the local behavioral health authority, which helps residents to kind of navigate, and we assess, where there's kind of supply and demand in the behavioral health system. Public health services, which I'll go into a little bit more later, and then services to end and prevent homelessness, which includes things like homeless prevention. The best way to keep somebody from being homeless is to have them not be homeless in the first place. And so we do a lot to help keep people in their homes or find alternative homes, to prevent evictions, to help with utilities. And then for folks who do become homeless, we have several shelters that we run in collaboration with partners. We have the Healthcare for the Homeless services, which Dr. Kelly provides. We have respite care for folks who are homeless and may have been in the hospital, and rather than discharging them to the street, we're able to discharge them to a facility to continue to get that medical care that typically they would be able to get at home. Think of things like wound care or IV antibiotics, but certainly would not want them to get if they were living on the street. We then kind of have the skeleton that supports all of those service areas. So our social service officer, Dr. Mensa, who does a lot of the child welfare, but also eligibility. So the screening for things like Medicaid and SNAP and WIC, those programs. Our planning and analytics team that look at our customer service, but also they're kind of the leading edge around technology and AI, and how are we creating dashboards and resources to really have the awareness on how our programs are doing, and thinking about the next level. Our Office of Community Affairs, Governance, Risk, and Compliance, legislation, and then our Chief Operating Officer, who likes to refer to himself as the skeleton, meaning nothing would move without him. It would all fall apart, but you don't see him, just the bones that make everything work. Diving just a little bit deeper into public health, we have 5 service areas within that as well. So community health, which includes our area health centers, our perinatal unit, which we provide home visiting services, the Babies Born Healthy program, which specifically targets African American moms to help reduce the disparity in Black maternal health outcomes, and our fetal and infant mortality child review board, which is always a sad meeting. We look at all of the fetal and child deaths within the county and see what we can do to strategize to prevent them from happening again. School health services. Well, no folks know that all of the school nurses within the county are actually employed by the health department, which gives us a great kind of insight and collaboration with the schools to kind of know what's going on. Licensing and regulatory services. This is what allows us to go to a restaurant and know that the food is safe. They're the ones who do restaurant inspections and pool inspections and rat and vermin inspections. Kind of that vital unsung hero of public health. Our community and population health team, they do our Montgomery Cares program, which I'll talk about in a little bit, but also tobacco control. They run our mobile health van, which goes to underserved areas throughout the county. And then lastly, our communicable disease and epidemiology team, which provide, there are contact tracers. They were frontline on COVID. They do STI testing and treatment, HIV treatment. We do offer PrEP through the health department. They also do tuberculosis treatment, syphilis treatment, all of those fun things. We are the primary, maybe only treater of syphilis in the county, so we keep pretty close tabs on that, as well as tuberculosis, and we do a home treatment, so we'll go do directly observed therapy for tuberculosis. So I want to share a little bit just around what Montgomery County looks like, the demographics of the county, how it's changed, both racially and socioeconomically, because I think it's important to know about the populations that we're caring for. So Montgomery County has really had quite a demographic shift in the last, 80 years, going back to 1960 when the county was 96% white to 2020 when it is 40% white, and the estimates are that is even lower now. And even when you look back between 2000 and 2020, we've seen that shift from a majority white county to a county where no racial or ethnic group makes up the majority. When we look at the diversity that exists within this county, in Maryland, about 16% are foreign born, but in Montgomery County, that number's closer to 33%. I think the most recent estimates I saw that it was closer to 37%. And when we look at the number of languages that are spoken at home, it is quite diverse. Only 60% of residents only speak English at home. When we have 7 standard languages that we translate into when we are doing kind of official publications, and I think on last estimate it was over 129 different languages spoken within the county. We also have quite a bit of socioeconomic diversity, and I think this is really important. So when you look at the median household income in Montgomery County, it's about $112,000 compared to Maryland, where that median household income is $90,000. The chart on the right is looking at the average income in households. And so I think what's interesting, so when you look at Black and Hispanic households, the percentage that make below 50,000 or above 100,000 are about the same. It's about a third. So you can, if you're looking at those populations, about a third make less than 50,000, about a third make between 50 and 100,000, and about a third make over 100,000. However, when you look at the county as a whole, 50% of the population is making over 100,000. And so just thinking about that kind of income disparity, and looking at, I think on the next slide, I'll talk about kind of what it costs to buy a home. There's quite a bit of income diversity within the county. It's also interesting looking at the percent of, so this bottom left is looking at no high school diploma, so no high school diploma in red, high school diploma in blue, and bachelor's achieved in green. And I think one of the things that stands out to me, so when you look at the top bar, the Asian population, while they have the second highest percentage of achieving a bachelor's degree, they also have the second highest no high school diploma. And so it's important to think about how we not lumping, right? And looking at populations and looking at the diversity that exists within populations. And so not just saying, oh, well, Asians have, high, over a bachelor's, very highly educated. Yes. And there's also a population that isn't, and we need to make sure that we are targeting communities or focusing on communities in a way that is, recognizing the diversity that exists within them, especially in a county like Montgomery County. This is just another kind of visual of that demographic trend. The On the left, the kind of bright lines, it's starting at 1980 and it goes up to 2015. The top line is the total population. The second blue line is the white population, and the purple line below that is grouping of non-Hispanic, I'm sorry, non-white population. And you can see where those crossed in 2010. And then just the dot map on the right, it's just representing the diversity that exists within the county. Every dot is a resident color coded by race. And so it's a great kind of visual of the population density and then also kind of the diversity that exists throughout the county. And this is just, where folks come from in the county. So 37% of county residents were born in a country outside of the United States. And it's just, I think, interesting to see kind of where those countries, where those areas across the world folks are coming to. I don't have a slide on it, but one of the things we had a recent presentation to the leadership in the county. And if you feel like, as I often do, that you are living in a bubble in Montgomery County, it's because we are. So there are only about 55 counties in the entire country that do not have a majority white population. Of those, there are only about there are only 13 where no racial or ethnic group has more than 40%. And when you look at those with income breakdown, we are the highest. So we are a rarity amongst rarities in terms of diversity and income. And so if you feel like there's no place like Montgomery County, it's because there is no place like Montgomery County, which is good and can be a challenge. I think it's a fun challenge. Yeah, go ahead, Dr. Rockwauer.
Yeah, I was just wanted to ask, of this 37% of county residents who were born outside, is that the majority of the people who don't have high school degrees? Is there a correlation there?
No,
That
well, we don't have the data broken down that way, but I doubt it.
Okay.
Yeah, just intuitively thinking about who, I think there's just as much diversity in who is coming here and coming with degrees and without. I mean, even if you think of just the medical population and folks, IMGs who are coming, I think in Montgomery County, especially, maybe more than other places, we attract a lot of folks that are foreign born that come with higher degrees
Okay.
than other places. And then this just looks a little bit at that income disparity again. So the dark red is median income of less than 50,000, and the dark green is a median income of 250,000. And you can see where it is in the county, but I also think it's interesting, there's a lot of yellow and there's a lot of close proximity of those populations. You can see kind of the 270 corridor tends to have lower income, and then when you kind of work farther away from that. We also use something called the self-sufficiency standard, which is looking at what is to actually live. You hear about the federal poverty level. which is quite low. I think for a family of four in Montgomery County, it's around $50,000 or $60,000. That's not going to get you very far for a family of four in Montgomery County. So the self-sufficiency standard takes into account the kind of what it's really like to live in a county, and that standard for a family of four is about $91,000. And if you think back a few slides to kind of where the median income is for some folks, they are very far off um, from that kind of self-sufficiency standard. This is just looking at breakdown by age, gender, and race. Montgomery County is getting more diverse over time. You see the percentage. I think this is an important note to make. So when you look at the percentage of whites in the county, it has decreased, but the absolute number of whites has not decreased. So I think that's important. There's not white flight. People aren't leaving, but as we've had more people come into the county, we see that diversity. The county is also aging. We are expect to be, I think it was 50, I think it's 50 by 50. Don't quote me on that. I'll get you the exact number, but 50% of the population over 50 by 2050. We are increasingly getting older in the county. Part of that is probably because it's expensive to live here if you are younger, and people tend to come here, love it, stay, and we aren't necessarily bringing in younger folks. So I want to transition here and talk a little bit about the health of the county. So the Robert Wood Johnson creates the county health rankings. A couple of years ago, they changed how they release it. So they used to, within a state, they would rank the counties, and Montgomery County had been #1 for the last 14 years. I like to say we are the healthiest county in the state, and it's my job to keep it that way. 2 years ago, they changed, and so they don't rank them anymore. They just show you on a graph where you are. And so we're still the healthiest county in Maryland, even if they didn't give us the #1. You can see where we are. And in this comparison, you can also see that Montgomery County is one of, if not the healthiest county in Maryland. It's also one of the healthiest in the United States. So you can see kind of where we sit in comparison to the state average, as well as to the national average. And when we look at what are the things that are driving that, why are we doing so well? People live longer here. Our rate of premature death is 41% better than the state of Maryland, 43% better than the U.S. average. We have a stronger health infrastructure. So there are our access to primary care physicians is higher, our access to dentists, our number of preventable hospital stays are lower. Physical environment, so we have access to parks. Everyone has free access to recreation centers. The county for 2 or 3 years running now has made membership to rec centers with gyms free. We have better socioeconomic factors, so fewer children in poverty, and we also have fewer injuries. And with that, we do still see ongoing disparities. In non-Hispanic Blacks, we see more firearm hospitalization, higher incidence of HIV. In our Hispanic population, we see, again, higher HIV, higher chlamydia incidence, more births with late or no prenatal care. In our Asian and Pacific Islander community, we have seen increasing syphilis incidence, also births with late or no prenatal care, late breaking. With the Hispanic community, we've seen an increase in late to care prostate cancer in Hispanic men, which is a conversation that we've had, I think, enough. We often talk about prostate cancer in Black men. And what we've seen in the county is those rates have leveled out for Black men, but are increasing for Hispanic men. And we're seeing more of them come in with late stage prostate cancer. For Asian Pacific Islanders, diabetes, suicide mortality, syphilis incidents have been increasing, and we also have seen higher rates of lung cancer, which we believe is smoking related. Again, we haven't probably been talking enough with that population about smoking. And then in non-Hispanic whites, we've seen increases, relative increases in drug-induced mortality, suicide mortality, and falls higher than other ethnic groups. So in a county like Montgomery County, everybody has something that we can work on. I think, when we look at general health status, um, most, tend to rate their health very good or excellent. Um, and very few, for men, it's less than 8%. For women, less than 15% say that they have fair or poor health, which in comparison to state and national averages is pretty good. When we look at folks without insurance, so in the county, we have about 7% of residents without insurance. This is actually higher than what we see in the state of Maryland. However, one of the shining bright spots in Montgomery County is that we have something called the Montgomery Cares and Care for Kids programs, which provide healthcare access for folks who don't have insurance. And so a large portion of those folks who, while they may not have insurance, they do have access to healthcare, and it includes primary care, behavioral health, and dental. And it's specifically for folks who are low income and don't have insurance. So we're able to offer them access to care in ways that other counties aren't able to, which I also think contributes to some of our good outcomes. About 85% of folks in the county say that they have a primary care provider, which is a little bit higher than the state average. And when we look at the leading causes of death, the chronic conditions account for nearly half of all deaths: heart disease, cancer, COVID, cerebrovascular disease. I will note that back in 2021, COVID-19 was the number 3 cause of death. In 2023, it dropped to number 7. And what I have seen, I don't have final data yet. I feel like that's dropped even to below 10, I think, this year. We do a lot for maternal and infant health. We have several programs for birthing moms. We have the Babies Born Healthy program, which is specifically for Black moms to try and close the disparity gap. We also have the SMILE program that's run through our African American Health program. Both of them provide home visiting. We also have the Montgomery Perinatal Partnership, which also helps support low-income moms. The state made a big investment in prenatal care with the Birth Equity Act. So now all pregnant persons, regardless of immigration status, can have Medicaid during their pregnancy. And that has really been a game changer. In the past, the county would pay for that prenatal care and deliveries. And so now they have much more comprehensive coverage through Medicaid. We do still offer support classes, pack and plays, and other things to help support folks during their pregnancy. And I will encourage you to look at the Chronic Diseases in Montgomery County publication if you have, insomnia or want some light reading to review some stats. And I'm not going to go through all of this in terms of what county health departments do, because I want to make sure that we get to the conversation around what you guys are seeing, how we can better work together. I will go back just some of the things that as health officer I've worked on. COVID, certainly, that's not the number one thing that I'm working on anymore, thank goodness. Overdose prevention. So I chair the overdose prevention task force that looks at overdoses in the county. When I first came into the role, we were seeing quite a spike in youth overdoses, especially related to fentanyl. We thankfully have been seeing steep declines in that, but continue to monitor that. And we actually, in a couple of weeks, are going to have a steering committee meeting to develop kind of the strategic plan for looking at that going forward. Youth safety initiatives, we saw an increase in youth self-harm, suicidality, substance use, and violence and victimization. And so, in my kind of chief health strategist role, led a task force of county agencies, health department, police department, school system, juvenile justice, to talk about how do how do we do better by our youth, essentially, and what are those things that we need to be doing? And spent the last kind of year and a half leading that initiative that's now been handed off to children, youth, and families, working on the integration between behavioral health and primary care. I'm really excited at our mobile health unit. On the unit, we have medical, dental, and behavioral health. And in many areas, especially in our Poolsville area, behavioral health is the thing that is the most sought after and needed. And so being able to create that access. In my medical career, I have always worked at places that have had integrated behavioral health and primary care. So try to replicate that as much as we can in the county. Certainly working on reducing health disparities. A big focus for me right now is around maternal health. I want Montgomery County to be the leader in eliminating the Black maternal health disparity, while we also improve maternal health outcomes across the board. There is, if any place is going to do it, it should be here. Montgomery County has the 4 birthing hospitals, one of them being Holy Cross, which is #1 in the state county and consistently in the top 10 of birthing hospitals. Last I heard, it was #3. And we've had hosted a couple task force seminars around that. We had a big meeting in the spring that brought together the hospital partners, the community organizations, to address that. And then we had a follow-up deep dive on data in June, which kind of dovetails with reproductive health access. So I've talked a lot and want to stop talking and open it up for questions, comments, opportunities to partner and collaborate together. And I will stop sharing.
Dr. Davis, this is Aruna Nathan. I just wanted to thank you for your time and giving us this broad overview, showing us how diverse we are. And so thank you for that.
Thank you. It's great to partner. I will tell you that my other county health officer colleagues are jealous that we have a great partnership with the medical society. And so I think it's great that I get to, have an ex officio seat on your board and kind of know what's going on, and also that you all serve on the county commission, so the local health improvement commission, the commission on health, the Healthy Montgomery, all of those. And so they are not getting that type of engagement from the physicians in their community. And so it means a lot. I think it's really important to the health of the community that we're working together.
Dr. Davis, I get to see you more than everybody else, but I guess my biggest question is, part of what we're doing in the public health committee is looking at ways that we can partner. So what are some ways that you would suggest that we partner together, or is there areas of engagement that you think that would help you in doing your job and help the county when it comes to public health from the physicians that are members of the organization?
So one, I would say, let us be a resource to you. There's a huge push, right? All of us are now accountable for social determinants of health, for screening for them and figuring out what to do once you identify something. The health department is a great resource for that patient. When I was in practice, I only really thought about calling the health department if somebody had an STI or I needed a rabies vaccine or something like that. Like, we get calls all the time from the community because somebody needs food, or because somebody needs housing, or somebody's parent is visiting from another country and they're trying to figure out how to get XYZ medical service. Like, oh, my sister's coming from the Gambia and she's trying to find an endocrinologist, and can you help me navigate? So we get those questions all the time. Don't necessarily want my phone to blow up, but you can call me or email me if you like. If there are resources, we are working on updating the webpage to have a kind of doctor-ready site, so you don't have to weed through all of it. Right now, our webpage is awful. It's bad. I can't find anything on it, but we're trying to, in the redesign, that's something that I would really like to have, of okay, I'm a doctor and I need something for my patient. Where's the quick pick to find it? So that's how we can help you. In terms of how you can help us. So one, taking good care of your patients, right? Being there, being accessible for your community, that always helps. I think that there are opportunities for volunteerism, and we are trying to figure out what the best way to bring more volunteers into the system. So for Montgomery Cares and Care for Kids, we have a network of safety net clinics. And we pay them for seeing patients. That in its current state is not really accessible to the private practice. However, what we really, we had a big meeting today kind of brainstorming, well, how do we change the program? How can we get more folks accessible to that? What we really have a shortage of is in specialty care. And so thinking, would you be willing to take a pro bono patient every now and then? Would you be willing to take a few patients that we will pay you for? We do pay, it's not as high as what you're going to get for insurance, but it usually is about what the Medicaid rate is. And, we will pay for specialists to get our patients in when we need them. And so we're always looking for more specialists in that regard. Many of those Montgomery Cares clinics, so like in my private practice, could you take a patient, either a pro bono patient or maybe a patient that we pay you for in your regular practice? Or maybe you want to volunteer at one of our free clinics that we have. They're not, they're free for the patients. In one of our safety net clinics that we have across the county, some of the bigger ones, especially like Mercy Health Center, they take primary care, but they also have GYNs, and they've got a cardiologist that comes through, an endocrinologist, and so Caseman Clinic as well. So a lot of these clinics are always welcome to have volunteers who will, come and maybe do a evening or afternoon once a month and see their patients. I think the other thing is sometimes it can be hard for me to get a pulse of what people are feeling in the community and where things are difficult. And so please feel free to kind of reach out directly or through the medical society on kind of what you're seeing and hearing. I think, hopefully we don't have another COVID for a while, but there's going to be something. And whenever that thing is, hopefully it's not measles. Please don't let it be measles. We have that. We can have that sort of kind of early warning sign. I'm seeing this in my practice. I would love to hear from some of you on what are the types of communications that would be helpful from the health department? What do you want to hear or want to know? Are there things that you wish was coming from me or the health department more regularly? And Dr. Rockhour, I did see your hand, so go ahead.
Yeah,
It's not
just
that
to put in a plug, you were talking about the free health clinics. Mobile Med is another one of the free health clinics that is always looking for primary care and specialists. I used to work on that until I got sick last year. But I know there are other orthopedic surgeons that are doing these kinds of things, and I wish I could get back to doing that, but it may or may not happen. But these free clinics are really very helpful for the non-insured population. There's still a significant number of non-insured people who need health care, and it really felt very good to be able to uh, provide that care. I wish my Spanish was better because the majority of the patients I saw were Spanish speaking, but occasionally there was French, occasionally there was Urdu, and occasionally there was um, other languages. So it made for a fun and interesting process.
It is very satisfying, I will say, volunteering in clinics like that. Even after a long day of clinic, sometimes that feels more satisfying. Sure, Dr. Kelly.
So two things. I think this kind of skips ahead a little bit in our agenda, but for Hannah and I have been working, and most people on the committee know that I'm the chair for MidCab. So we've been working to try to build that connection with the safety net clinics as far as them being more specific about what specific volunteer areas they need. And then Dr. Vella, and we had talked before the thing today because I couldn't come. And Farhana are going to connect on how she can present to the committee and to the medical society as a whole with how they can help with specialty care, and what that relationship will look like. So those two things that you talked about, we are actively working on building that connection and building a pipeline for our physicians to be able to know what volunteerism out there, and have a way, like, know exactly what you can do to help, resolve some of the different issues in the county. And I think the biggest thing communication wise that will be helpful, that has been helpful, I feel like we don't have the trust we need in the federal level. So I think the things that we would depend on when it comes to numbers in the community of COVID, and um, if recommendations have changed. I think you and I have talked about some of the vaccine recommendations and things like that, and with the presentation we had at MidCap. So I'm privy to some information I'm sure other physicians are not privy to when it comes to that. So I think even if it's, you do this quite a bit of sending that out to the medical society for us to put in the newsletter, and to that you kind of are a trusted source of information that's coming down from the state and from the organizations that are now our trusted ears and our trusted voices for what's going on medically and with recommendations.
Yeah, yeah. Trying to share that. I know the state has joined in the Northeast Consortium and another consortium around like vaccine science, and to have the kind of trusted source, because we can't trust the federal partners in the way that we did before, which is unfortunate. And I kind of straddle this line of, I can't, not being able to just blatantly trust what comes out of the CDC anymore, and also not bashing the CDC, because we need the CDC to come back and be restored to its glory. And, I also don't want to, dispel so much trust in the CDC that folks never trust it again. And so, I often will just say, here are the sources that I am going to now, and not say the sources that I'm not going to, and try to walk the line.
I have a question, Dr. Davis. I don't know, I cannot raise my hand on the computer, but I'm raising my hand here.
I see it.
Yeah, so Dr. Davis, you mentioned thank you so much for this great presentation. We really learn a lot about the Montgomery County. And I have a question, like you mentioned about you're working also on the mental health. So young adults, they have a lots of mental health going on, and especially after the COVID, they are suffering from long COVID syndrome and other stuff, anxiety. It's very hard in the Montgomery County to find a child psychologist and child psychiatrist. How you can help in this issue?
It is not easy, and that is true. And that is true in many senses, regardless of whether you have insurance or not. One of the things that we are excited about that just it launched earlier this year, but they had their big press conference about it just this past Monday, is a tighter connection between the Behavioral Health Authority and the schools. So there's a hub and spoke model that's going to be happening with the school system in partnership with the health department. The health department will be kind of the administrator to make behavioral health treatment more accessible through schools. It doesn't get to everybody right now. Everybody goes to public schools, some people learn private schools, some people don't feel comfortable. But it isn't necessarily all of that. The care will be provided in the school, but that school will kind of serve as we're calling it like a hub and spoke model. Like that's a place. The schools haven't traditionally referred people out for treatment unless they're at the highest level, right? Until you do something wrong. And so being able to better refer folks out for resources and providing some funding for those. So I would say it's coming, and we're expanding that network of the school being the place, because it has the biggest touch for kids to be able to get resources to folks at a lower acuity. So not just, once you've had a suicide attempt. One of the things that we saw a lot as I was doing the research on the Youth Safety Initiative is there's a lot of doors that unlock once somebody falls off the cliff. So once somebody has a suicide attempt, once somebody has an overdose, once somebody gets arrested, there's all of these resources that are available, but nobody knows about them earlier or can't access them or the doors aren't open. And so a lot of that partnership is to try and get those resources to people earlier before they have that negative outcome.
And
So I
here's
can
where
send some of that after.
Yeah.
Got that
Here-
expo.
Here's where I'm going to put on my advocacy hat. As you all know me, I'm always pushing for advocacy in the state. We need to lobby our legislators for increasing funding and resources in the Medicaid system and in all these other mental health and public health systems. And I understand there's a problem with the state budget and things coming out of Washington, and that's going to be a problem in the next few years. But it's something that we always need to be thinking about. For the longest time, I was one of the only Medicaid accepting orthopedists in the state in Montgomery County. And so people would be coming down to me from Frederick and from Washington County for their care. And maybe we can convince some of our Washington and Frederick County compatriots to to help participate in some of that, just because that's what we're supposed to do as physicians. But anyway, the point I'm making is we need to get more money into the system.
Yeah, we do. And it's going to get harder with the changes that are coming. And thank you for being a Medicaid provider. I think that's, I'll get on my Medicaid soapbox for a little bit, having more providers in the system to take Medicaid is a game changer for patients. So especially in Maryland, Maryland has put so many resources into Medicaid. From a health department standpoint, we are now billing for Medicaid in a way that we didn't before because, they have cut the grant for tuberculosis funding because they want us to bill Medicaid for it, right? Because that's where they put the resources. They've cut the grant for tobacco because now Medicaid will pay for tobacco cessation, right? The investment in expanding Medicaid and making that available to so many folks means that's where the money is. And so having patients have access to that and having more physicians who take Medicaid is such a huge, huge benefit for the community, takes the burden off the health department. But, it's also one of those things, if we each take a few, it doesn't feel like a lot. I know, for procedures, no, the Medicaid reimbursement isn't as good as some others, but for, your traditional 99213s and 4s and 5s that aren't procedure related, that reimbursement is pretty much on par with Medicare. And so, and I still will say that your 36-year-old Medicaid patient is probably easier than your 86-year-old Medicare patient. So trying to, encourage folks to take more Medicaid folks, especially in this county. And, what we're dealing with now is what's going to happen when a lot of folks who had Medicaid lose it. And that's just going to make care more expensive for all of us.
And just to add to that for Dr. Rockhour, we are very lucky. Our county council president, her whole initiative this year is on behavioral health. So she just held a behavioral health, I don't know if I want to call it symposium, but a kind of a think tank for the county a few weeks ago. So I do think that from a advocacy standpoint, that has been helpful to have her, really be pushing behavioral health as her initiative for this year.
Sounds good to me.
Great. Thank you so much, Dr. Davis, for joining us and going through your presentation and answering our questions. We're really trying to put this public health committee together and direct our efforts more appropriately. One of the things we covered was the safety net clinics. Another huge thing that we've been trying to figure out is how to talk about vaccines and that with our patients and within the community. And is that a place for us as this committee to do, and how we can work with the health department with this, and if you have any insights on that, and how to campaign this, how to message this, and try to build the trust between physicians and patients.
Yeah, I mean, I think around vaccines continuing to be the trusted messenger, when they poll patients, they do still trust their doctors on recommendations around vaccines. Even though, the mistrust is high, and they, when you ask patients, they do still trust what their doctors say around vaccines. So continuing to be an advocate for vaccines. We don't have much in the county for uninsured folks. So uninsured kids, no problem. We've got VSC. Uninsured adults, we don't have much of a resource. We've got 25 vaccines for COVID. We should be getting more. The state is kind of sent out the trial balloon on what would you do with these 25, how would you prioritize, and they are figuring out the funding to be able to provide more for uninsured adults. If you remember, last year was the first year that the COVID vaccine went through the insurance system. Right before that, it was just free. Federal government just paid for it. Last year, you had to bill it through insurance. That was hard because insurance is hard. But the Biden administration had a bridge access program, so uninsured adults could go to, I think there were a few pharmacies, and the health department had it where they could get it for free. So if you were uninsured, you could still go to CVS, Walgreens. I think there was one more where you could get it. This administration is not paying for that. The state is trying to replicate that in some way. They're just trying to figure out the funding. I think the whole thing with SNAP delayed things because they were putting probably vaccine money into SNAP. Now they'll get it paid back. It's going to take a while. Hopefully we get that money before fall respiratory season ends. The vaccines aren't worth it anymore. So there's some effort to try and promote that. But I think being the trusted messenger and continuing to tell folks how it's helpful, and that it prevents hospitalization and prevents death and prevents long COVID, and the long-term effects is continues to be helpful.
Great, thank you. Are there any more questions? Okay, well, thank you so much for just joining us, Dr. Davis. The public health committee is going to continue to stay on to go over some business. So thank you for everyone who's joined, and if anybody wants to drop off, feel free to, and then the rest of us can stay on and discuss further.